Audio recording for this meeting has begun.
Good afternoon, and thank you for joining us today for Unpacking the Rainbow, Improving Clinical Experience for LGBTQIA Patients Using Cultural Competency. My name is Hannah Wicke, and I'm the Communications and Provider Services Manager for the Wyoming Primary Care Association. I'm also the Special Populations Contact for the WYPCA to HRSA. Today I will be co-presenting on this topic with my colleague Scott Cheney, our Clinical Project Manager. Some of today's material you may have seen before, but we wanted to make sure that the content is relatable regardless of where you fall on the knowledge spectrum with this population. We wanted to cover this subject material to also introduce that the WYPCA will now feature in-house expertise for matters regarding the LGBTQIA population.
Your microphone has been turned
Scott came
on.
with previous expertise and has enhanced it through additional training, and now will serve as a point of contact to ensure that ongoing technical assistance is available at the local level. In addition, during this webinar, we will be referencing fantastic resources that are readily available to improve anyone's knowledge on working with LGBTQIA patients. Before we get into the content, there are a few things I would like to cover. Please keep your phone lines muted until we get to the Q&A portion of the presentation, but feel free to make use of the chat box whenever the mood strikes. However, we won't address any questions submitted until we get to the Q&A portion of today's presentation. We have an evaluation that will be sent out via email to all registrants, and it is also available as a link in the pod listed under the titled Web Links. Your feedback is extremely important as it is used to determine our future efforts and helps us learn how to be better supporters and partners of your work. Scott will now take us into our presentation. Thanks again for joining us today.
Thank you, Hannah, and good morning, everybody. We're going to start this off by going through the various acronyms in the LGBTQIA+ rainbow. Starting off easy with lesbian, gay, and bisexual. Lesbian, or women who have sex with women, typically describes a female who experiences romantic love and or sexual attraction to other females. Gay, or men who have sex with men, describes males who experience romantic love or sexual attraction to other males. Bisexual is a romantic attraction, a sexual attraction, or sexual behavior to both males and females. Transgender are individuals who feel that the binary genders of male or female assigned to them at birth is a misleading or incomplete description of themselves. Too many times we ask the question, when do we say trans woman or when do we say trans man? You say trans woman to refer to an individual who is assigned male at birth and now lives or identifies as a woman. You say trans man to refer to an individual who was assigned female at birth and now lives or identifies as a man. Queer is an umbrella term that's now used for sexual and gender minorities that are not heterosexual or cisgender. Queer was originally used as a pejorative term against LGBTQ individuals, but it has been reclaimed by queer scholars and activists and is now commonly seen in academics. Q can also stand for questioning, which is the questioning of one's gender, one's sexual identity, sexual orientation, or all of the above. It's important to note that sexuality is a process of exploration, and those who are still exploring, they can be concerned about applying a social label such as gay, lesbian, or bisexual, and prefer to just say that they're questioning. Intersex, or historically called hermaphrodite, is an individual born with any of several variations in sex characteristics, including chromosomes, gonads, or genitals that do not allow the individual to be distinctly categorized as male or female. Asexual, or non-sexuality, is a lack of sexual attraction to anyone or a very low or absent interest in sexual activity. And ally is an individual who considers themselves a friend to the LGBTQIA+ community. Typically, these are heterosexual, cisgender individuals who want to show their support for their friends or family who are LGBTQ. And then you have the plus category, which can be a lot of different things, but these are typically what's seen under plus. Pansexual, which is a sexual, romantic, or emotional attraction towards people regardless of sex or gender identity. Agender, which literally translates to without gender. It's a non-binary gender identity or just a non-gender identity. Genderqueer is now an umbrella term for all categories of gender identity that are not exclusively masculine or feminine. Bigender is dual gender. It's a gender identity that includes any two gender identities and behaviors, such as masculine and feminine, or agender and androgyny. Gender variant is a gender non-conforming, and pangender is being more than one gender. Individuals consider themselves member of all different genders. So, too often you just want to ask the question, so are you gay or straight? And it's important to know that it's not that simple. Behavior does not necessarily equal identity, which does not necessarily equal orientation. Looking at the health disparities facing LGBTQIA, the first is to look at the literature that's out there. The vast majority of publications related to human health do not cover the topic of LGBTQIA healthcare. In fact, in 2011, the Boston Globe did a research study of publications put out by PubMed and found that only 0.21% of them included an LGBTQIA+ related keyword. Additionally, LGBTQIA healthcare is vastly undertaught in medical education in the United States. The Journal of the American Medical Association reports that out of 150 reporting schools, the typical time spent on the content in the entire curriculum was 5 hours or less. The fact of the matter is that LGBTQIA individuals face the same health risks as the larger society, but they also have multiple additional factors that impact their health, such as a cultural history, perceived or actualized discrimination, ever-changing laws and policies, major barriers to access, and a lack of culturally humble providers. We could frankly spend hours looking at the hallmarks in LGBTQIA history, but for this presentation, we're only going to go over major events from the last 60 years. Starting in the 1950s, which what has now been called the Lavender Scare. This was led by Senator McCarthy, who considered homosexuals as dangerous as communists. This was a systematic witch hunt which led to the mass firings of homosexual people who worked for the U.S. government in the 1950s. In fact, in 1953, President Eisenhower signed Executive Order number 10450, which barred homosexuals from working in the federal government due to security concerns. In 1969, you had the Stonewall riots, which were violent demonstrations by the LGBTQIA+ community against police raids. This highlighted to the public the very real issues of prostitution, drug use, and sexual abuse that plagued the LGBTQ community, particularly in poor urban areas. While now the Stonewall riots are looked at as a source of pride for many in the LGBTQIA region, these riots were used by the larger society to reinforce in the conservative ideology the hedonism and wild nature that is often associated with the LGBTQ. We saw the beginnings of the HIV/AIDS epidemic in the 1980s. First identified in 1981, the rapid rise of HIV and AIDS decimated the LGBTQ population throughout the country, particularly in areas where LGBTQ individuals formed tight-knit communities, such as the Castro in San Francisco and the Village in New York City. Due to the conservative nature of the country and the rampant homophobia, political response to the epidemic was slow. There was a huge amount of distrust in the gay community as well, towards public health reports and measures which had unfairly targeted LGBTQ populations before. This epidemic was treated as the gay plague, and serious public reaction did not happen until various celebrities announced their own HIV diagnoses, until the Ryan White case occurred, and various organizations began hosting their own red ribbon campaigns. In 1998, the world became familiar with the name Matthew Shepard. This is a story that many of us are familiar with. In October of '98, University of Wyoming freshman Matthew Shepard, a young gay man, was robbed, beaten, and tied to a fence in a prairie outside of Laramie, Wyoming. Throughout the trial of his attackers and even at the original funeral in Casper, the Westboro Baptist Church descended upon Wyoming holding signs that said, "Matt in hell." Since then, there have been numerous instances of alternative narratives of the event that paint Matthew as a deviant or a drug dealer, despite all of the evidence to the contrary. Not until recently, in fact, 20 years after his death, has his family been able to put his remains to rest. In the early morning hours on June 12, 2016, a man opened fire inside the gay nightclub called Pulse in Orlando, Florida. At the time, this was the deadliest mass shooting in the United States and was considered to be the nation's worst terror attack since 9/11. 49 people died and another 53 were wounded. While this act was denounced as a hate crime by multiple groups, including the Vatican and the Council on American Islamic Relations, it further enforced the fact that to be LGBTQIA can be dangerous and it can be fatal. Recently, the Department of Health and Human Services has issued a memo where they are leading an effort to establish a legal definition of sex. In this process, they are seeking to define gender as a biological and immutable condition determined by genitalia at birth. This new definition would eliminate the federal recognition of an estimated 1.4 million Americans who recognize themselves as a gender other than the one that they were born into. Additionally, in 2018, we still have high rates of violent crime towards trans individuals. Thus far in 2018, 22 transgendered people have been killed. 82% of them were trans women of color. And 74% of known victims of anti-transgender violence in 2017 reported that they were misgendered in police and media reports. We go through that brief history to illustrate the fact that those who are part of the LGBTQIA community have learned over time and have seen with their own eyes that to identify as LGBTQIA can be dangerous, embarrassing, and ostracizing. These feelings can be amplified when they need to seek medical care and they do not know how their medical provider will react to their gender identity, their sexual orientation, or their sexual practices. The study in front of you was performed by Lambda Legal in 2014, and it surveyed a number of LGBTQIA individuals as well as HIV-positive individuals. Within this study, 89% of transgender respondents and 49% of LGB respondents reported that there are not enough health professionals who are adequately trained to provide them care. And 85% of trans individuals and 52% of LGB individuals reported that they have a fear of going to a medical provider who will not like them and may react negatively. When we're looking at the issue of access, LGBT individuals have lower incomes than others with similar educations and similar occupations, and they are less likely to be insured when they are compared to others in their similar backgrounds. Additionally, many insurance plans that are available continue to exclude transgender care despite the non-discrimination regulations put forth in the Affordable Care Act. Harassment, victimization, and violence are extremely prevalent in LGBTQIA youth, as is depression, suicidal ideation, and suicidal attempts. They also have those in the LGBTQIA community also have a higher prevalence of smoking, alcohol abuse, substance abuse, and HIV/AIDS. Cultural awareness of the providers, as well as a lack of willingness or knowledge in how to ask the tough questions, has a major impact on the lives of their patients. For example, transgender individuals can have an increased risk for cancer because their provider does not know the patient's history or is unwilling to ask. Trans female individuals who have not fully transitioned need to be checked for prostate cancer, and trans male patients may need to be checked for breast and cervical cancer. This is a major missed opportunity on the part of the provider, and since the testing does not happen, the research shows that trans patients will present at a more advanced stage of disease than their cisgender counterparts. The overall bias and stigma in our society and the lack of education creates an unwillingness for LGBTQIA people to disclose to clinicians personal information that could be necessary for proper diagnoses and treatment. While this lack of disclosure about sexual orientation or gender identity can lead to inadequate care, these disclosures can also lead to LGBTQIA people being more vulnerable to discrimination and violence. The misinformation that is out there about LGBTQIA and the attack on federal protections can lead to high levels of shame, isolation, depression, chronic stress, and countless other issues within this population. This then leads to individuals neglecting their physical and mental health, which can increase suicide risk, substance abuse, and not presenting to a physician until their medical issues are in later stages.
So now that we've provided some background on the LGBTQIA population and the health disparities, we're going to transition to talking about SOGI data, starting with the origin story of SOGI data collection. So first, the National Institutes of Health turns their attention to trying to understand the health disparities the LGBTQIA population faces. Second, they realize they don't have the data resources needed to draw upon in order to understand the problem and ask the Institute of Medicine to evaluate the existing gaps in research. And this isn't the first time the medical community has run into these types of problems. Prior to 1990, racial and ethnic data wasn't collected in the way it is now. It was implemented following the realization of cancer researchers that they didn't have the necessary data resources to assess cancer risk, incidence, and outcomes. The Institute of Medicine publishes the report that was commissioned by the National Institutes of Health. The report inspired the National Institute of Health to create the Sexual and Gender Minority Research Office. Then, in 2011, based on its findings, the Institute of Medicine, which is currently known as the National Academies of Sciences, Engineering, and Medicine, calls for research investment into the public health of the LGBTQIA population. Next, in 2014, a study is published on SOGI data collection. It takes place at 4 health centers located in both rural and urban settings. 301 patients were chosen at random to complete the SOGI questions and then were posed follow-up questions. The majority of respondents, both heterosexual and LGBTQIA, completed the SOGI questions and stated in the follow-up questions that they would respond to SOGI questions in the future. In 2015, HRSA requires SOGI data to be collected by its grantees and entered as part of UDS beginning in 2016, and requires that all EHRs certified under Meaningful Use Stage 3 have the capacity to collect SOGI information from patients. In the this came in just this week, in the 2019 Communicable Disease Voucher Program guidance, SOGI data collection will be required of sites participating in the No-WIO voucher program for STD testing. This is in addition to the data entered into PRISM, and this additional data collection is required by all recipients of the CDC STD Prevention Grant, which is what provides the funding for the No-WIO program. Even with the new information provided by the study, there are still some negative attitudes that exist around SOGI data collection from the provider viewpoint. A study featured in the Journal of American Medical Association in 2017 found that 80% of emergency department clinicians believed asking SOGI questions would offend patients. With that said, I hope this slide in particular will be helpful. To reiterate the findings of the 2014 study, of the 301 patients that were posed SOGI questions, only 12% strongly or somewhat disagreed that the information provided by SOGI was important for the provider to know. Best practice is to include SOGI on intake forms, and then if those questions aren't completed, the clinician should ask in the exam room. Respondents from the study indicated that staff training to ensure that intake understands and can express the purpose of SOGI was important to providing culturally competent care. This is actually so important to a few respondents that they expressed they didn't think SOGI questions should be posed during the intake process at all. This was to avoid the instance that staff would not be culturally competent in the delivery of the questions. So now we are going to watch two videos from the National LGBT Health Education Center that can be used to help both front desk and clinical staff with implementing this best practice in a culturally competent manner. These and other videos are available on the upcoming resource slides and will also be linked to on the WYPCA website. The doctor will be able to speak to you in a few minutes. In the meantime, if you could please fill out the forms and then return them back. No problem.
Excuse me?
Yes, how can I help you?
I don't really understand why it's asking me about sexual orientation.
Oh, well, I don't know either, but it's required, so just write something down.
In this scene, the registration assistant appeared uncomfortable with the patient's question. Rather than providing information about sexual orientation and its relevance to patient health, she told the patient to just write something down. The next scene show a more effective way to respond to the patient's question.
Hi. The doctor will be able to take you in a few minutes, and in the meantime, could you please fill out these forms and then return them back to me?
Great, thank you.
No problem.
Excuse me?
Yes, how can I help you?
I don't really understand why it's asking me about sexual orientation.
These are new questions for all of our patients that are important for healthcare. Here's a brochure with more information, and you can discuss this more with your provider, who will welcome your questions.
Okay, great. Thank you. I'll talk to my doctor.
No problem.
In this scene, the registration assistant helped the patient by providing an informational brochure and by suggesting a discussion with the provider. She made eye contact with the patient, spoke without embarrassment, and mentioned that the question was being asked of all patients.
I see you left these questions on sexual orientation and gender identity blank. I'm sorry. I can clearly see you're not gay or transgender, but I'm required to ask. So should I put down female and heterosexual?
Yeah, I guess.
In this scene, the clinician made several mistakes. First, he apologized for asking questions about sexual orientation and gender identity. Second, he assumed the patient identified as female and heterosexual. By doing so, he made it very unlikely that the patient would feel comfortable being honest with him. The next scene will show a better example of how to ask a patient about sexual orientation and gender identity during the clinical exam.
We've begun asking patients about their sexual orientation and gender identity so we can provide the best care to everybody. Can you tell me about yourself? Do you consider yourself straight, heterosexual, gay, lesbian, homosexual, bisexual, or something else? If you're not sure, I can explain what these terms mean. And you can also say, I don't know.
Oh, yeah, I saw that. I was wondering what that was about. What does bisexual mean again?
Bisexual is a person who is attracted to more than one gender.
Oh, well, I only like men.
Okay, that would be heterosexual. Is it okay if I put that down on your medical record?
Yes.
Thanks. And do you consider your gender identity male, female, transgender, genderqueer, or something else?
I don't know what half those things mean, but I know I'm a female.
Okay, and were you assigned the female sex when you were born? I ask this because some people have a gender identity that is different than what is traditionally associated with the sex that they were assigned when they were born.
I've been a girl since I was born.
Great. Thanks for helping us fill that in.
In this scene, the clinician started the conversation by explaining why the health center is asking patients about sexual orientation and gender identity. When the patient asked about the meaning of the word bisexual, The clinician was able to explain it to her in a clear and respectful way. The next scene shows another positive example of discussing gender identity with a patient.
I'm looking at the questions that you were given at registration, and I see you left a question about gender identity blank. And I was wondering if you had questions about this, and whether we might talk about how you think about your gender.
I don't really want to talk about that.
If confidentiality is a concern, I can assure you that this information will be kept private, and only relevant health center staff will be able to see it.
Well, that's good to know, but I still don't want to talk about it.
That's okay. Can I put down choose not to disclose in your medical record? This means that you've decided not to share this information at this time.
Yes, that would be best. Thank you. In this scene, the clinician asked the patient an open-ended question about gender identity. When the patient declined to talk, the clinician explained how the information would be kept confidential. When the patient declined again, the provider did not pressure the patient and gave the option to not disclose.
All right. Oh, now the video show up. Sorry about that. So I don't consider this a tangent, but some might. I wanted to include some cultural competency tips for older adults, as Wyoming is supposed to expect a gray tsunami in coming years. Again, referencing that 2014 study, people who are over the age of 65 were more likely to not understand the options listed under the SOGI questions. This doesn't mean that people over the age of 65 will approach the front desk to ask, but in the instance they do, it's important to know that 1 in 3 Americans that are between the ages of 65 to 74 has some hearing loss. It is recommended that if someone has questions and a hard time hearing the response to, number 1, don't yell at them. Speaking slightly louder can help in some circumstances, but not all. And number 2, find a solution that can accommodate them. The Arizona Commission for the Deaf and the Hard of Hearing suggests reducing background noise and possibly moving to a quieter location. Sometimes making your face and mouth clearly visible can help those who lip read. They also recommend using shorter sentences, slowing down your pace, and to keep movements while speaking at a minimum. In addition to these suggestions, leveraging the best practices covered in the previous slide will help in this situation as well. Your front desk person can hand them a brochure, and we have a link to the free downloadable version on the resource slides, and we'll also have it on our website, and can communicate to the patient that the provider will answer their questions. This is a great option for healthcare organizations that do not have a quieter space readily available for those at the front desk to use. In case you are not already familiar with the recommended SOGI questions, I have them listed here. Also recommended is a pronoun question. And then to see a full registration form with these questions, there is a Callan Lord form that is included in that resource slide, and again, it will be available on the WYPCA website. So all EHRs or EMRs certified under Meaningful Use Stage 3 have the capacity to record SOGI data as of January 1st, 2018. However, customization to an EMR is required in order to effectively record and make use of SOGI. At this time, it is recommended that healthcare organizations contact their vendor first before doing so. Some of them have best practices available for their customers. 2 of the major recommendations for EMR customization is to create a field for pronouns to facilitate the use of the correct pronouns for a patient by all staff. This is important to culturally competent care. Some health centers have color-coded these as well, and then for patient mailings, some healthcare organizations have transitioned to using Dear Patient. Overall, you want your EMR to make your life easier and meet the needs of all your patients with reminders set for clinicians to examine the anatomy present. Make sure that gender and sexual orientation is entered separately because, again, some transgender women may need a prostate exam and some transgender men may still need screenings for breast and cervical cancer. Before we leave this slide, I wanted to mention that as SOGI has rolled out, it has been found that even facilities that specialize in serving LGBTQIA have struggled with making the EMR, EHR work for them. We are learning and progressing together, so be sure to contact your EMR vendor to make use of anything they may have to offer to assist with this customization. And then I also want to emphasize that without proper EMR documentation, clinicians are forced to rely on patient-supplied forms that may be incomplete. So the next section is all about taking next steps to grow your LGBTQIA patient population. The first thing you'll want to do is to make sure that your health organization looks welcoming. As mentioned previously, there's a lot of uncertainty and hesitancy to accessing health care for this population. I try to organize these strategies into steps based on how much effort is required for implementation. So number one, recognize that you probably have LGBTQIA patients already coming through your doors. Even if you are currently collecting SOGI data and have not had anyone identify as LGBTQIA, a survey conducted by the Annals of Internal Medicine of over 4,000 men in New York had 12% of them respond that they had sexual relationships with men, but of that same 12%, 72.8% self-identified as straight. In a more recent qualitative study in 2017, it found reasons for non-disclosure included that the provider did not ask, internalized stigma, as well as a belief that health and LGBTQIA identity are not related. Number two, look at your waiting room through your patient's eyes. What communications are featured in your waiting room as they are filling out the SOGI questions and waiting to meet with a provider? Featuring brochures or posters specific to LGBTQIA creates an inclusive environment to welcome people of this community. It helps when the available materials they see relate to issues that are important to them and features people that look like them. We have several sources of these types of communications that will either send you free printed versions of materials or has them available for free to download. Number three, go beyond SOGI and take measures to gain additional LGBTQIA input to help improve your organization. You can add a question about SOGI in your patient satisfaction surveys or recruit an LGBTQIA patient to your board. Number four, acknowledge events that are important to LGBTQIA, such as Pride Month in June, Transgender Day of Remembrance on November 20th, or World AIDS Day on December 1st. You can do so on your organization's social media pages or in your waiting room. One idea for your waiting room is to hang a pride flag during Pride Month. There is also a great poster available from Out for Health that would be an excellent fit for Pride Month, which again is going to be available on the resource slide. Another way to acknowledge these days is to do so internally with a staff training. There are lots of great online trainings out there, and you are more than welcome to use the recording of this webinar. Finally, number five is develop a comprehensive resource list that staff can use for appropriate referrals to services that LGBTQIA may need. By creating a welcoming environment, you are creating the opportunity for positive word of mouth to your current patients that may be LGBTQIA or to your current patient's son, aunt, cousin, friend, etc. I'm going to turn it back over to Scott to cover some other strategies you can try to increase your LGBTQIA patient base.
It can definitely be a struggle to connect to new patients in a community, and these are just a few of the options available to you. There are a couple actual provider directories that have the opportunity to connect you to LGBTQIA patients. The first one is from GLMA, or the Gay and Lesbian Medical Association. They have a national directory that they maintain and update regularly on their website and is visited tremendously by a lot of LGBTQ people. Additionally, Wyoming Equality has a provider directory on their website under resources. Both of these websites are constantly updating their directories, and the best way to get on the list is you just simply email them under the contact session and say that you would like to be put onto the provider list. There's also the opportunity of targeted community outreach. Most communities in the state of Wyoming will have local GSA or Gay Straight Alliance organizations that you can reach out to. Alongside expanding print materials for your waiting room, those can easily be taken with you for outreach events to health fairs or community events and just put out on a table. And an LGBTQIA person walking by will see that, and they can connect the name with someone who's culturally sensitive to their medical needs. Additionally, on the same Wyoming Equality website, there are numerous support groups throughout the state of LGBTQIA people that welcome outside presentations, especially from medical providers.
So these are the ongoing education resources that was mentioned throughout the presentation. So first we have the SOGI data collection resources. This first link is going to connect you to those videos and as well as additional videos that can provide information on various topics around SOGI data collection. The second one is the Spanish translation of those SOGI questions. The next one is about cultural competency. This is a great presentation that is featured on the WYPCA website. The part that we really wanted to kind of highlight today, because we weren't able to get into it, is the importance of language. As we had mentioned previously, using the correct pronoun is very important to providing culturally competent care. So beginning on slide 24, they highlight the importance of language. There are CE-eligible trainings available for clinical staff. SAMHSA has a great collection of behavioral health equity trainings, and then the National LGBT Health Education Center has a great collection on various topics. We mentioned communication materials that you could include in your waiting room. So the first link there is that About SOGI Patient Education brochure that you could use as part of your implementation of that best practice. Next are free printed tobacco cessation brochures, posters, and then a Healthcare Bill of Rights card. There are free downloadable materials on multiple topics from the LGBT Health Education Center. There's a free printed transgender abuse survivor brochure. There are free downloadable posters from Out for Health, and that was the one that I had mentioned. They had a really great version that could be used for Pride Month. And then there's that sample intake form with the SOGI questions included on it. And then as Scott has mentioned, we included links to those provider directories. And then these are the resources in case you wanted to do some additional reading yourself. And then we're going to transition into the Q&A portion of the webinar. I'm going to unmute all the lines. Let us know what questions you have.
Hi, Hannah and Scott. This is Brenda. I do have a question for you.
Hi there, Brenda.
Hey, great presentation, you guys. I really appreciate it. As a healthcare provider, you know, I'm trying to be very careful when I work with a patient to make sure I call them by the proper pronouns. What would be your advice if I mess up?
That's a great question. One thing to note is that transgender individuals who grew up trans have known for a long time that they're trans and have had a whole life of being misgendered by family and friends. And so when it happens from, especially from like a medical provider, they can take it sort of as a microaggression. And I've talked to quite a few trans individuals to ask what is the best reaction essentially from a healthcare provider when they realize, oh, I just used the wrong name or I used the wrong pronouns. The best thing that a provider or clinical staff can do is just stop, look the patient in the eye, and apologize and correct themselves. Don't try to laugh it off or don't make a joke out of it. To them, it's a really big deal, even if it doesn't seem like it's a big deal to you.
Great. I appreciate that perspective. Thank you.
Thank you. Any other questions?
Feel free to enter in the chat box too. I know sometimes I don't like to vocally pose a question, so feel free to do it that way as well.
This is Helen from Champs.
Hi there, Helen.
Hi, how's it going?
Good, how about you?
I'm doing well. My question is on how, given not just the political climate, but any given community climate, that question around safety. I know the video sort of addressed it, but how you assure a patient that this information will be used to help them and will never be able to hurt them.
I actually think the video did a great job. The provider reiterated that, you know, it's in a confidential system, but also that limited people within the organization will have access to it. It's kind of good to know maybe to know how many people will definitely have access to that. And it's also great even just to reference HIPAA stuff for patients who aren't necessarily aware of it.
Great, thank you.
Again, I think the video did a really great job of not pushing too far. You don't want to put the person in a defensive position when they're already uncomfortable. So, just kind of covering, that it's confidential and then not trying to push it any further, I think is really, really important. Okay, so we have in the chat box, are the brochures available in other languages? So I didn't see a lot of the ones that I came across and included in the resource slides. They're all in English, but I could definitely go back and look again and see if there's also a Spanish version available or other languages as well, if that would be helpful. Oh, nice. Nat says Fenway has brochures available in Spanish, Chinese, and other languages. And the one specifically about SOGI is from Fenway, so then you'll be able to have that available in other languages as well.
Eric in the chat box says, how is it best to make those over 50 feel comfortable disclosing their sexuality? They seem unlikely to self-identify. That's very true, and I wish I had an easy answer to that. The over 50, you have to think about the world that they grew up in. Most of the history that we went through, they saw that persecution against people who are just like them. So they're not likely to identify, and it's going to be pretty common on those intake forms that they're just going to be blank. Again, it's great to look at the actions of that physician in the National LGBTQ video where he noticed that the questions were blank, and then in the safety of the exam room, he asked the patient the question there so that the patient isn't having to give it to a front desk person that he doesn't know or an MA that he's never seen before.
And also time helps with that. I mean, if you have a patient that comes through your organization several times and they see that you're trying to make an effort, like including those additional communications in the waiting room and acknowledging those holidays or putting things out on your social media page, and they see that you're trying to make an effort, sometimes it might take them a while for anybody to get comfortable. But if you're making, an effort that they can see and that they can recognize, you're taking steps to open yourself up to the opportunity that they will disclose to you. But it may be, a process. It may take time.
And that's a great point. A lot of research in LGBTQ healthcare in rural areas cite that time is the biggest toolkit that a provider can have. When the patient may not disclose the first time, they may disclose the 10th time, and then you have to add that into their record. But the patient has to get to know you, they have to get comfortable with you and with your facility. A couple people are typing.
You don't only have to use the chat box. It was just an alternative as well. You can also ask questions, over the phone.
This is Helen again. I have another question, if that's okay.
Great.
So do you guys have any advice on how to respond if someone, potentially a non-LGBTQIA patient, responds sort of negatively to these questions?
So in that study, there were people that responded negatively. I believe the number was, but it wasn't actually that many. Of the 301 patient respondents to that 2014 study, to even explore whether or not people would be open to answering SOGI data questions, only 12% of them said that they were either, slightly against or strongly against those SOGI data questions being posed. I think you have to really bring it back to, highlighting the purpose behind it, because it is about collecting information that will help some people, get the health services that they need.
We have a question in the chat box of if there's a directory with contact info for medical providers who are LGBTQ. And I'm really not aware of a directory with providers who self-identify as LGBTQ. However, it's a good bet that those directories from the Gay and Lesbian Medical Association, or GLMA, a lot of those physicians are probably LGBTQ or have individuals within their practice who identify. Sue asked the question if gender identity is a very complex subject, and I'm wondering if gender identity is being discussed in the schools. The easy answer is probably not in Wyoming. Much of the sex ed or much of the sex ed programs throughout Wyoming are pretty stagnant in boys are boys, girls are girls, and don't delve a lot into trans or the different various gender identities. Unfortunately, in rural areas, a lot of those resources will come from medical providers. Sandra,
this is Rob Johnston in Casper. We're finding that I'm president of the local PFLAG chapter, and we're finding that more and more parents who have transgender children are willing to take the issue to the schools. And there are some great resources online that they are printing off and taking in to help schools address some of these questions. So it's happening around the state, but really on a one-to-one basis kind of thing, as opposed to a policy.
That's great to hear. Thank you very much. I know that the local PFLAG chapter in Laramie is doing a similar thing, trying to get in with the high school as well, and are presenting to the school board in the new year, so that'll be good. Sandra, you asked the question if the term cisgender is the same as heterosexual. No. The term cisgender means that the individual is the gender essentially that they were born with and that they portray. So, for example, I was born male, I dress as a male, and I live like a male, so I am a cisgendered individual. Got a couple other questions coming in the chat. Okay, Helen, thank you. She says, most importantly, you identify as male. Lots of transgender people never get to dress or express their true identity. That's very, very true, and that's especially true in rural areas. I don't know if some of you remember, I think it was about a year ago, the big thing that happened with Senator Enzi and an individual in the state of Wyoming who dressed to express who they were. He was born male but dressed as a woman, and it led to the whole the tutu campaign. So yes, thank you, Helen. It can be very difficult for transgender people to be able to express who they are. And unfortunately, in states like this, we don't have a lot of areas. Sandra, you also point out that Jackson High School has an LGBTQ support group. That's wonderful. Ag workers, if a provider needs to refer an LGBT patient to another provider, would you discuss the patient's gender identity? I would first ask the patient what they wanted me to do as a provider. And then I would also ask myself, is the patient's gender identity in relation to why you're referring them? Or does it have any impact on why they're being referred? I would especially consider it if the patient goes by a name other than the one that's on their legal paperwork.
That's a fantastic question. I think we'll probably find a resource or create one ourselves and then do some research and then probably put that out in a future biweekly or maybe add it to our resources under the website because I think that's a very relevant question that's not necessarily easy to answer.
I've got a couple more coming in the chat box. Oh, thank you, Sue. We were excited to do this presentation. Are there any other questions?
Thanks, Alan. That's great. And if there's no other questions, feel free to pipe up. But we also want to have a now I can't think of the word. Help me. No, an evaluation form. Sorry, it's featured. It's listed in the web links box under follow-up survey, and we'll also be sending this via email. And feel free to reach out to us. You know, this is something that has been important to us for a long time, and we're really trying to ramp up in this area. So, you know, anything that we can do in terms of adding resources to our website or, you know, future topics we can touch on, or even if you just want to call and you know, get a second opinion, feel free to reach out to us. That's what we're here for, and that's what we want to do. All right. Well, thank you, everybody. Again, please fill out that evaluation. And then I would just like to say that our next webinar will be December 18th on the topic of peer specialists. We have national, regional, and state presenters that will provide practical information attendees can use to discern whether a peer specialist is the missing piece from their current care team, as well as what you would need to start a program at your organization. Thank you so much for joining us today. Really appreciate it. Have a great afternoon. Yeah.